Us in person from the Council of Canadians, Nikolas Barry-Shaw, Trade and Privatization Campaigner. It's an interesting title. From the Conference Board of Canada, Eddie Nason, Director of Health. And joining us by video conference from the Montreal Economic Institute, Emmanuel Forbet, economist, and Daniel Dufour, President and CEO. Thank you so much for joining us today. We will begin with opening remarks from Mr. Shaw and Mr. Nason, followed by Mr. Dufour. You will each have 5 minutes for your opening statements. Mr. Barry-Shaw, the floor is yours.
Thank you, Madam Chair. I'm the Trade and Privatization Campaigner, but for the last 2 years or so, I've been more or less a full-time Pharmacare campaigner with the Council of Canadians. We're a grassroots membership-based organization. We have 30 chapters across the country. We have over 150,000 supporters of our work. And throughout the campaign for Pharmacare, we have organized 18 town hall meetings on Pharmacare in cities and towns across the country. We've collected over 10,000 signatures of people calling for a national Pharmacare plan, and we've placed more than 5,000 phone calls to MPs and cabinet ministers in favor of Pharmacare. What we have been demanding through this campaign is a national Pharmacare program that is public, single payer, and universal. And we are calling for the Senate to pass the Bill C-64 without amendments because we believe this is a critical step towards that goal. The need for such a program has never been clear. I know we've had some discussion here about the extent of the problem, and I think I just want to underline this point, is that access to medicines was already a crisis before the pandemic. Since the post-pandemic inflation, it has gotten even worse. And so in the briefing that you'll be receiving, I believe it's being translated, we show that according to the most recent surveys, 22% of Canadian households report someone who is unable to afford their medication. They're either skipping doses, they're cutting pills, they're not renewing their prescriptions. So that's a huge number of households for whom the cost of medication is an enormous struggle. We know that cost-related non-adherence is an even bigger issue for people with diabetes, and that cost is also one of the main barriers to women and gender-diverse people getting access to contraceptives. So we think this is urgently needed, and we don't want to see the bill delayed any further. And I think I would just also like to underline that this is not a problem that is only for people who are uninsured. I think some of the debates have got mixed up with that. We've heard this statistic cited of 97% of Canadians supposedly being eligible for some form of insurance. In our campaigning and in our discussions and the feedback that we've received from members and supporters about their struggles with the high cost of drugs and inadequate insurance, the problem is more often than not that the cost of drugs is so high that people cannot afford to access them even with coverage, right? Because there are cost-sharing mechanisms in most public plans, because there are cost-sharing mechanisms in most private plans, this is a real problem even when people have coverage. So the Hoskins report showed that 6 out of 10 people who are reporting cost-related non-adherence are people who have coverage under an existing plan. Recent polling that's been done shows that it's possibly 7 in 10 people who say they are having great difficulty affording their medications are people who have existing coverage. So I think I just really want to underline that point, that the importance of this universal first dollar coverage starting for these 2 classes of medications. And I think we are looking forward to seeing that same standard expanded to drugs as they are added to the formulary on the essential medicines list. I think the discussion was really rich before, and I had some prepared remarks, but I just wanted to jump into the question of the ambiguities of the bill and just very quickly say that I think we recognize them, but we feel that they are less at the level. We think there are also many strengths in the bill. I think particularly Section 6.1 is pretty clear that the coverage will be universal, single-payer, first dollar, and that it will be the funding for that first phase of the program will be for public plans. And so that's one of the reasons why we want it passed without amendment We think it's setting a precedent. We think there's a political opportunity here that we really need to seize. But I think it's also crucially important to safeguard the policymaking process from conflicts of interest, from corporate actors who are trying to influence this process. We've done a tremendous amount of reporting and research on lobbying of the ministers and his top officials throughout the development of the Pharmacare legislation, and this is something that we see continuing today. I think we're very concerned that the CDA and the Committee of Experts be free of conflicts of interest, and I think I would reiterate Matt Herter's point that it's vitally important that people on those committees not only disclose their conflicts of interest, but are excluded from them if they have any ties to the two industries that stand to lose the most from a public single-payer system, namely pharmaceutical companies and the insurance industry.
Thank you. Mr. Nason. Am I saying it correctly?
Yes,
Nason, like
that is
Mason?
correct. Nason, yes. So good afternoon, everybody. I am Eddie Nason. I am the Director of Health at the Conference Board of Canada, and I'm very happy to be here today to be able to discuss our work on prescription drug coverage. This dates back to July 2022, when the Conference Board of Canada published a report called Understanding the Gap 2.0, a pan-Canadian analysis of prescription drug insurance coverage. And this was an update to a previous analysis called Understanding the Gap that was done and released in 2017. Now, in this study, which I think has been mentioned a couple of times, there was an estimate that it was only around 3% of Canadians who were not eligible for some form of prescription drug coverage, either through their provincial public plans or through private sector plans. And that was actually a drop in the gap looking at the previous estimate in 2017, where it was around 5%. And you could see that that change was driven predominantly by OHIP plus introduction in Ontario, where it actually provided drug coverage to about 1.3 million more children and youth. And so that upped the numbers from 2016. So when we think about the uninsured population, that is those who are not eligible, it represents two provinces, Ontario and Newfoundland and Labrador, that don't have either a universal public drug coverage, a set of programs that are open to the whole population, or enough programs to cover their full provincial population, or where their public plans cover those that do not have private coverage, so fill in the gap on private coverage. Sometimes in the case of high drug costs, those who are not insured in those two provinces may still become eligible for catastrophic drug coverage that will be provided by their province. However, even with eligibility for plans, 10% of the Canadian population in this study were not enrolled in a public or a private plan. And again, that was down slightly from previous estimates in 2017. In addition, even with high enrollment in plans, we still see, as Nikolas just mentioned, that many Canadians don't actually have access to the medications that they need. And that's caused by a variety of reasons. And this analysis identified a few of them: an inability for lower-income households to cover out-of-pocket drug expenses, differences between what medications might be available between public and private plans or across different provincial plans, the time to access for newer therapies in public drug plans, which tends to be slower than private plans, so people on private plans may get access to drugs before those on public, or plan coverage caps or spending limits, meaning full courses of treatment might actually incur out-of-pocket costs for individuals. These access issues align with social inequities in Canada, in particular with household income levels, with ageing populations with multiple comorbidities who require more medications, and with racial and ethnic backgrounds of individuals and families. Thank you for the invitation to participate. I look forward to discussing the report further with this committee.
Thank you very much, Mr. Nason. Mr. Dufour.
Merci.
Thank you very much for inviting us to discuss a very important issue, drug insurance. C-64 gives rise to major concern about its impact on the quality of coverage and access to drugs for our fellow citizens. In effect, it ignores an essential principle of public policy, namely that we must first avoid doing harm to others. At present, 24.6 million Canadians have a private insurance plan, representing roughly 65% of the population. Unfortunately, a universal plan would threaten the quality of coverage for at least 21.5 million Canadians. On average, private plans cover 51% more drugs than public plans. This reduction in the quality of coverage is simply not justifiable. What's more, setting up this national drug plan will be extremely costly. According to the Parliamentary Budget Officer, the total cost to the federal government would approach $39 billion by 2028, including $13.4 billion at the federal level alone. This additional spending would put considerable pressure on our public finances, which are already weakened by a net debt of $1.3 trillion and recurring deficits on the horizon. At present, it takes an average of 732 days for new drugs to be approved under a public system, compared with 226 days for private plans. Patients do not have the luxury of seeing drugs delayed even further. Today, some 1.1 million Canadians are not eligible for any drug coverage at all. And it's important to put in place measures that are going to help them without doing harm to the rest of the population. So instead of introducing a national drug plan that could disrupt existing plans and reduce the variety and quality of drugs available, we should be focusing on expanding coverage for those who don't currently have access to it. In essence, what the government is proposing here is to rip away from working Canadians the drug plans they work hard for and their families depend on, and would replace them with much smaller plans. As with any public insurance program, the costs will have to be contained. Inevitably, this will be done by restricting the offering, fewer drugs covered, and longer waiting times. This is not a flaw in the system, but one of its essential features. In conclusion, although a national drug insurance scheme might seem attractive in theory, in practice it presents many risks and disadvantages, and we must and can ensure that all Canadians have access to the drugs they need without compromising the quality of the existing coverage. I encourage you to consider these elements and to work together to find solutions that will improve the lot of all Canadians rather than harming a clear majority of them. Thank you for having listened to us.
Thank you very much, Mr. Defort. We will go now to questions from our colleagues, starting with the Vice Chair of the Committee, Senator Cordy. We will limit questions and answers to 4 minutes and see how far it takes us.
Thank you very much. Mr. Nason, thank you very much. I've heard read many reports from the Conference Board of Canada. You do some great work. I'm wondering, you spoke about 3% of Canadians having no private insurance. Correct me if I'm wrong. I was writing pretty quickly. And some provinces have catastrophic drug coverage. My province of Nova Scotia has drug coverage for seniors. But what I'm wondering is, you spoke about all of the percentages and all of the different categories, but you didn't say whether or not you're in favor of this bill. Was that intentional? And could you maybe tell us a little bit about it?
Yeah, just to clarify on the 3%, the 3% is the proportion of Canadians who are not eligible for any kind of coverage. So that's whether they have private, public, or any of the public systems that exist in Canada. In terms of this bill, I think I would say that I am in favour of it conceptually. And as was identified in the last session, there are some challenges with how it might be implemented.
Okay. That was very diplomatic. Mr. Barry-Shaw, thank you also for the statistics and the information that you gave us. You spoke about that there are ambiguities in the bill, but the premise of no cost is enough, and that the idea that so many people that you have spoken to have in fact said that it is a necessity for them. I wonder if you could expand on what you've heard from people, number one, and number two, what happens if we amend this bill, in your mind?
Yeah, I mean, we've had the opportunity to meet a lot of people throughout the last 2 years. I'm thinking of people like Rebecca Redmond, who's actually a descendant of Sir Frederick Banting, who's the inventor of insulin. She happens to have type 1 diabetes, and she participated in one of our town halls. And there she said, you know, it's like having a second car payment, right, dealing with diabetes. It's tremendously expensive for people. I think of people like a nurse from Saskatchewan who wrote to us. She was working full-time. She had, you know, kids, adult children at home who needed medications, and so she had some coverage with her work. But the medications were so expensive that the co-payments she had to make, the co-insurance payments she had to make, were just beyond her means. And so, you know, her daughter wasn't going to university. Her son wasn't able to hold a job because he wasn't getting the medication he needed, you know. So I think eliminating the fact that the program is universal, that it would include people like this nurse from Saskatchewan, people like Rebecca Redmond, people who have some coverage but are still struggling with the high cost of drugs, is vitally important. And the fact that we are making it, you know, a healthcare service like any other that's recognized to be medically necessary, and that we're not going to put a cost barrier between people and accessing that, I think is a very important principle, and I hope it sets a precedent going forward.
Thank you. And I was very shocked last week to pick up medication and have a copay of $70, which for me didn't mean that we wouldn't have groceries or anything, so we were very fortunate. But for some people, it would be having to make very difficult choices. So is it important that this bill be passed as is?
I think we have a window of opportunity to do it. I hate to echo the health minister's points. We're often at odds on a lot of other issues with the government, but on this point, I think he is right. From what we've heard from our allies who have spoken to members of parliament and stuff, we're not sure if it would pass with amendments. And you know, the Council of Canadians has been calling for Pharmacare for like 2 decades, and we really do feel that it is time to get this started and to set a precedent and hopefully build off of that. And I would say that the kind of the way of proceeding, where there's going to be an expert committee that will look into it and then decide whether, you know, do we do the PEI model or do we do a public single-payer model? In my mind, there's no doubt, right? We heard from Marc-André Gagnon and Steve Morgan and other experts who have been working on this. Every single serious independent expert panel that's looked into this has said, yes, we need to move towards something that is single-payer, that will bring down drug costs and include everybody. So if the government is willing to listen to the expert advice that it's going to get, I'm certain what the answer
Mr. Barry-Shaw. Senator Seidman.
Thank you, Chair, and thank you very much for your presentations and being here today. To all our witnesses, I think I might start with you, Mr. Nason. So yesterday, the Parliamentary Budget Officer confirmed to the committee that the estimated program costs assumed that Canadians who already have workplace coverage for drugs covered under a national Pharmacare program would be expected to continue to access those benefits through a workplace plan. That was the Parliamentary Budget Officer and his estimates. And so my question is, how is this consistent with your understanding of the term universal single payer, Pharmacare? And the PBO also told the Parliamentary Budget Officer, sorry, we tend to use these acronyms, he also told the committee that private employers would have a clear market-based incentive to drop coverage for products captured by a national Pharmacare program and would, and I'm quoting, remove it through collective bargaining. So are you concerned about the likelihood of a reduction in workplace coverage that the PBO confirmed on behalf of union members, really?
Yeah. Yes. I think it's inherently an incentive that if you create a system where you are identifying that you are willing to pay for certain things, then other people will not be willing to pay for those things. And so it's going to create a challenge when you try and create a system that is weaving together other systems and saying we will just cover gaps within it, rather than, as Steve Morgan identified, creating the floor and then identifying how you build upon that floor with the things that would be incentivized for other payers to be implicated in paying for.
So in fact, we heard from these Canadian experts, and they truly are, who testified before, that passing this bill would be more dangerous to the potential of ever having a real universal system in this country. And do you believe that? Or do you agree with that? I'm sorry, I should be asking you.
I think I would certainly defer to their expertise on the ability to create full working pharmacare systems. It's not an area that I have done massive amounts of work in, or the Conference Board themselves have done massive amounts of work in. So I think their opinions are probably more valuable than mine.
Thank you. Do I have any more time?
Yes.
Okay, thank you. I might ask you, Mr. Dufour, first. If I have time, I'll go to Mr. Barry-Shaw. But Mr. Dufour, you mentioned in your presentation fewer drugs would be available and a slower availability. There's less of an availability, at least it takes far longer for a drug to be available in the public system. Probably, I think it's about a year longer than in the private, by a private insurer. And so I'd like to ask specifically about the current list of diabetes products proposed by Health Canada, if you've had a look at it and if you think it's sufficiently comprehensive compared to those currently available through workplace benefit plans that have been negotiated through collective bargaining.
De façon bien honnête, on n'a pas.
Quite honestly, we have not specifically analyzed the drugs for diabetes. We focused on the principle itself, the principle of drug insurance. And what we observed is that private plans cover 51% more drugs than public plans. So you can imagine that as this program expands and costs would need to be contained, you would further limit access to new drugs, and that delays would be lengthened, similar to what is happening in the public health system or any other program where the public regime has a monopoly. Thank you.
Senator Osler.
Thank you, Chair, and thank you to all the witnesses for being here today. And my question is for Mr. Barry-Shaw from the Council of Canadians. And you mentioned in your testimony that the Council has been calling for national pharmacare for 2 decades. And I believe the Council has been calling for national pharmacare as envisioned in the Hoskins report. And you heard testimony from the pharmacare experts earlier today saying that passing Bill C-64 as it is currently written would be a, quote, dangerous precedent, end quote, to achieving universal, single-payer, first dollar, public, national pharmacare in the future. Given the testimony we've heard today, you mentioned you've had conversations with the minister, I would appreciate hearing the Council's view. Like, how would Canadians react if that vision of national pharmacare did not come to fruition?
Well, I think maybe I disagree with the premise of the question. I guess we do think that this will set us on a path that can build towards a public single-payer system. We've had a lot of discussions about the question of shifting, people moving from private coverage to this public, basically creating a public lane, right? It's not quite single payer, but it's basically creating a public lane where it's a public program that is entirely funded by the federal and provincial governments. It's universal, it's first dollar coverage. I think that will expand and it will draw in the vast majority of Canadians, because the vast majority of Canadians are covered by an existing plan that requires them to pay out of pocket some amount for those drugs. And so I think it has the potential to move us towards that, right? And I think if people see that people are getting diabetes drugs, people are getting contraceptives through this program, they'll be totally justified to ask, well, okay, well, why not cancer medications? Why not blood pressure medications? Why aren't we covering this in the same way? And I think this is one of the kind of really widely held beliefs of many Canadians, is that healthcare should be a right. It should be accessible to everybody based on their need, not on their income. And so I think doing that for two classes of drugs is going to set a positive precedent going forward. I hear the ambiguities and the concerns, but I think for us, our assessment is that it's much more at the level of political will that the danger exists. And I think the pharmaceutical industry and the insurance industry have done a lot to try to sap that political will. I think this discussion here of the idea that people are going to lose their existing private drug coverage because of the creation of this public lane, it's nowhere in the bill. It's nowhere in the Hoskins report. The Hoskins report is explicit that you'll have private supplemental health benefits that can cover drugs that are not on the national formulary, right? So I feel like we are often operating in a political environment where there's a lot of disinformation that's been put out by corporate actors who have a very clear vested interest in opposing the arrival of Pharmacare. And I think that's at the level at which the fight will continue. I think it will also be fought out at the level of the provinces. And we've seen a lot of registrations of lobbyists from the pharmaceutical companies and the insurance companies at the provincial level. As soon as Bill C-64 was unveiled, they started reorienting their efforts towards influencing provincial governments. So I think, I agree with Steve Morgan's point that if this passes without amendments, which we would like, there is going to be a political struggle to be had at the level of the provinces to make sure that the standards and the shape of the program we want to see come to be is realized.
And I apologize. Perhaps I phrased my question incorrectly. I wanted you to gauge your
Senator
reaction to
Osler.
the testimony.
Thank you, Senator Osler. Senator Meji.
Merci, Madame la Présidente.
Thank you, Madam Chair. I've listened to what Professor Barry-Shaw explained, especially concerning the Saskatchewan nurse. And the Conference Board of Canada published an article, quite an exhaustive article, on the complications of diabetic feet. So for 4 million on nursing care, might one not think that C-64 might at a certain point in time become a Canadian investment rather than expenditure? I mean, we know that at the beginning there is a big investment, 1.9 billion, and that appears huge. But by avoiding diabetic patients to develop complications that are so costly, would it not be better to consider it as an investment? Can you tell us what you think?
Puisque vous faites partie du Conference Board. Oui.
Yeah, I think I agree that I think any approach to pharmacare, national pharmacare, is an investment, and that you acknowledge that there are upfront costs that lead to cost savings elsewhere in the system. And that diabetic foot care study and report is a good example of how, when you potentially make new investments, you can reduce the costs associated and the healthcare outcomes and the individual outcomes associated with those diabetic complications. So I don't think there's any argument that it's potentially a wise investment. But as with most investments, it's how you make your investment that matters, and how you monitor and support that investment through time. And so I think that the whole national pharmacare discussion is not just that it's a good idea. I think we generally acknowledge that as a public good and potential investment good, it is a good one. It's how you make it work that has been mentioned that I think is going to be the thing that decides whether it's a good investment or not.
Okay, merci. Une autre question?
Thank you. And I do have another question for the Montreal Economic Institute. In February of 2024, you published an article on the dangers of a drug insurance program in Canada. Did you share those concerns with the House of Commons committee when they studied the bill? This for Mr. Dufaur. I couldn't tell you if any of my colleagues did so. As to myself, no, I did not. No brief was produced and sent in that regard either, not to my knowledge. But I'm not always aware of what each of our employees does.
Thank you, Senator Meji. Senator Cormier, followed by Senator Moody.
Merci, Madame.
Thank you very much.
Mr. Barry-Shaw, and I'll ask it in English. It's on behalf of the sponsor of the bill, Senator Kim Pate, and she wants to know this. We hear arguments that moving to a universal public single-payer system will disrupt coverage or even leave Canadians with less coverage than they currently have. Can you expand on how and why, in your view, single-payer coverage will make access to medicines better or worse? So that's the question from Senator Pate.
Yeah, I think from what we've heard from the government and what this bill lays out is it's going to be leveling up the existing coverage for the drugs, the first two classes of drugs, for provincial plans. So the federal government is investing, providing transfers for provinces to level up their coverage to a standard that is first dollar and universal. So they would have to eliminate, the existing co-payment structures or the existing restrictions on eligibility for public plans and to make it truly universal. That's how we understand the first phase of the bill functioning, and that doesn't do anything to people's private coverage. It may incite them to shift over. And so, for myself and in my work, I have a workplace plan, right? If I had diabetes and I needed a medication that was on the national list, I decided to use that system. The worst thing the only thing that would happen, and I would hope it would happen, is that my employer would renegotiate lower premiums because they wouldn't need to cover me anymore because there would be less claims for diabetes drugs because now this national Pharmacare plan was covering a certain portion of the drugs.
Merci. Ma deuxième question, je vais la poser en français puis
My second question I'll ask in French, and it's for each one of the witnesses. Dr. Gagnon earlier talked about drug waste, and we know that in Canada there is a challenge of overconsumption. Now, C-164 would have the minister publish a pan-Canadian strategy on the appropriate use of prescription drugs. Now, in your opinion, what would be the main components of this strategy, and how could a national strategy on adequate consumption of drugs influence the underconsumption, the overconsumption, or the poor use of prescription drugs in Canada? Who would like to answer first? Mr. Dufort, might you like to tackle this? If you'll allow me, such a strategy would be to educate how Canadians should best use medications and influence Canadians to use medications properly. But that would not impact the quality of the coverage of medications, which is also important. Would anyone else like to comment?
Very briefly, I think a strategy like that, one of the things it should probably do is investigate and require greater transparency in terms of payments that pharmaceutical companies make to doctors to try to influence their prescribing habits. I know that this isn't an area where I'm an expert, but I know Dr. Joel Lexgen has done a tremendous amount of research on this question. And has said that Canada has very lax regulations around this aspect in particular. And I think the problem in Canada is one of, a kind of classic problem of poverty amidst plenty. We have some people who have too many medications. I think the fentanyl crisis and the opioid crisis is a very good example of this. And then on the other hand, we have a huge number of people in Canada who are struggling to afford medications that they truly do need and that would improve their health immensely.
Just very quickly, while we have not done work in this, people like Choosing Wisely Canada have done great work on appropriateness, appropriate prescribing, inappropriate use. And so I think they have set the precedent for how that might fit into an appropriateness strategy for the country. And then thinking about those knockover effects to what does that mean in terms of what gets prescribed, where you see substitutions of generics, those sorts of things will become part of that appropriateness conversation. So I see it becoming a good place, but we have good Canadian background data for it.
Thank you. Merci, Madame la Présidente.
Thank you, Senator Cormier. Senator Moody, followed by Senator Bernard.
Thank you, Madam Chair. Mr. Barry-Shaw, this question is for you. We've heard from all academic experts that should this bill pass with no amendments, that certain things become more important, essential. One of them is that the Committee of Experts becomes the accountability arm of the future, where it comes to understanding, is Pharmacare working? Is it going to the right people? Are they getting what we promised, et cetera, et cetera? As written in the bill, do you think the language is firm enough, tight enough, explicit enough that gives the Committee of Experts the power they need to manage data, get data, understand where things are trending in this country, and have the power to influence future decisions? Do you think the language is tight enough? Are there changes there that you think we need to see?
I'm going to have to plead ignorance on that particular point. I spent a lot of time considering other aspects of the bill, but I'm not sure I have a convincing answer for that. I think I've corresponded with the experts that were presenting earlier, prior to the presentation, and we've had a lot of discussions about this bill, and I think a lot of the amendments that they are proposing are positive and go in the same direction as the Council of Canadians and many other national organizations that support public single-payer Pharmacare. I'm just concerned that the cost-benefit, the risk that we're running of the bill getting bogged down and not passing or taking a very long time to pass and delaying the rollout of the program is a much bigger risk than the gains that we would receive from clarifying certain elements of it. It is a tough call. It is a tough political question that we've been wrestling with.
Second question, you recommend that we send a message to the government, essentially, not an amendment. Are you confident that this will achieve what you hope it will achieve?
I think by itself, probably not. I think it is one way in which the Senate can contribute to pushing the government in that direction. I think we will continue. We've talked a bit about political pressures on the government, and I think that one of the reasons the bill is what it is because there was a counter pressure, right? The Council of Canadians have talked about our campaign. We did a tremendous amount of lobbying and urging the government to act on this thing, as did many unions and many health coalitions. And so I think what we'll need to do is we'll need to continue to do that. I wish I could just go home and relax and be confident that everything would work out. But no, I think we're going to have to be extremely vigilant going forward.
Thank you.
Thank you, Senator Moody. Senator Bernard.
Thank you, Chair. Thank you all for your testimony today. I appreciate it. I have a question based on a comment I think one of you made about the small number of Canadians who are not eligible for any current coverage. Who are they? Who's in that number? If you could remind us of the percentage you talked about, but I'd like to know who they are and whether or not this bill, as currently presented to us, will address the problem.
Yeah, so this is from work that the Conference Board did looking at data in 2021. That was around 3% of Canadians who were not eligible for any form of insurance, prescription drug insurance. And so it is driven by two provinces, so Ontario and Newfoundland and Labrador, where there are not full universal coverage, or there is not essentially a coverage that is in existence for those who do not have private care, private health insurance. And it tends to align with people who have lower socioeconomic standing. It tends to align with people who are younger people who don't have access to private health care. and don't fit into the older age public health system, public health, drug systems. And whether this bill addresses it or not, as I think it was Steve Morgan who said that this bill he described it as terse in the way that it was written. I don't think it gets into much detail about whether it would achieve that for this group of people. And I think that despite the number being 3% on those who don't have any ability to be insured, the aim of the Pharmacare bill is to make sure people have access to the medications, not to just being insured. And that number is far larger. And that's the issue that I think really needs to be addressed. And as you have so saliently pointed out, there's a massive equity challenge in how that gets done.
You have a comment as well, Mr. Barry-Shaw?
Yeah,
Yes.
I mean, I'm glad that we recognize that the problem is much bigger than the 3%. The trouble with the 97% statistic is that it's served as a pretext for minimizing the problem and for saying we don't need a universal single-payer system. And it's been used again and again and again in op-eds written against this bill, written by often think tanks that are funded by pharmaceutical companies and the insurance industry. And this particular statistic, I don't know if it was disclosed in the materials that you've provided to the committee, but it was from a study that was funded by Innovative Medicines Canada, which is the chief lobby group of the drug industry in Canada. It was based on data that was provided by the CLHIA, which is the chief insurance industry lobby group. And it was based on an original study from 2017, which was designed by 2 members of IMC, Innovative Medicines Canada, and 2 members of the CLHIA. So we kind of get bogged down in a lot of these discussions when we're talking about things because they've been thrust into the public sphere by commercial interests. And I think it's kind of slowing us down when the real issue is the far larger number of people who can't afford their medications, whether they're covered or not.
Thank you, Senator Bernard. I think my question will be for Mr. Barry-Shaw. Casting our eyes beyond our border, other countries, like-minded jurisdictions, do have universal pharmacare. How does our model, proposed as it is, compare to others?
It compares extremely poorly. I think it was the Hoskins report that found that levels of cost-related non-adherence in Canada were 2 to 5 times higher than in other countries that have nations that have a universal drug insurance programs. We pay some of the highest drug costs per capita. I think the PMPRB's last annual report said we are now second. We were third for a while. Now we're second in terms of drug prices, just behind the U.S. The U.S. is in a class of its own, we understand. So this is a system that costs a lot, that leaves a lot of people still unable to afford their medication, and it has a tremendous amount of administrative inefficiencies. And I think this is something that Dr. Marc-André Gagnon has spoken and has written at length about how having, thousands of public plans, hundreds of public plans, tens of thousands, hundreds of thousands of private plans creates just a tremendous amount of administrative overhead that would not exist in a more streamlined public system.
Thank you. Senator Cardozo, and then second round, Senator Osler. Yeah?
Thank you, Madam Chair. I'm not a member of this committee, but I'm watching it very closely. I've been a long-time supporter of Medicare, and my view is certainly that of Pharmacare. My view is certainly that Medicare, which started, I think, 67 years ago, this was the one piece that was missing. I think we're catching up to the missing parts of Medicare. We're talking about dental care, mental health care, and Pharmacare. So to me, this is a really important part of it, no question. The question for me is this the best way to go, and is this bill the best way to approach that? I think we're the only country in the OECD who have Medicare who don't have Pharmacare. So there's no question we need to move in this direction. Let me ask you about this. Is that a fair kind of philosophical approach? Do you agree with that? And I think the answer is yes, but if you can add more to it, I think that helps. If it's not 97% that's covered, what is the figure that you think is covered? And I'd ask both Mr. Barry-Shaw and Mr. Nason to comment on that.
Yes, I'll start. The numbers that I cite in the brief that I've submitted in terms of cost-related non-adherence, so people who can't afford their medications, we're talking about 22% of households where there's somebody who can't afford their medications. So that's a huge number. And then in terms of people who are saying they're suffering financial distress, people who are saying they're having difficulty affording their medications, maybe they're filling their prescription, but they're having to cut back on other things. Some surveys suggest it's as high as 40%, right? People who are saying that they're having trouble. So this is a huge number of Canadians. For some people, the problem is more serious, and it is more serious for people who have absolutely no coverage in general. But it's a problem for many different people, and it's not always obvious. It's often our system ends up acting like a tax on the sick. You get an illness, and you suddenly discover that you have to pay a tremendous amount out of pocket in order to continue living. And I think that's just an obvious injustice, and this program should change that.
Yeah, I think in answer to your first question, yes, I think Pharmacare is, as you say, one of those key aspects that will add to that Medicare conversation that has not been addressed yet. So I think philosophically, I would certainly agree with that. And I don't think there's any disagreement, certainly from the conference board's work, with what Nikolas has just said. I think that we identified that 3% is those people who don't have eligibility for anything. That is not the number of people who cannot afford their medications. We go through some other percentages in that report to get to the idea that, that there's 10% or so who aren't enrolled, even though they might be eligible. But then when you get past that 10%, you then get into these people who are not able to afford their medications, or who are able to afford them but then have to forego other things. And so those proportions that Nikolas is identifying do not seem out of the ordinary in terms of the number of people who may actually benefit from having a Pharmacare approach.
Do I have time for one quick question? So if I can just go to a couple of details in the bill. Section 4D refers to providing universal coverage of pharmaceutical products across Canada, so it's all. And then you go to 6.1, where they talk about for specific prescription drugs and related products intended for contraception or the treatment of diabetes. So it seems almost contradictory that 4.1 says all, but 6.1 refers to two issues. What the minister said was, it seemed to be saying, I don't want to put words in his mouth, was that 4D was what they were really talking about, and 6.1 came about as a result of negotiations between him and Don Davies, and I can see how those sorts of things happen. What's your feeling about the difference between those two?
Yeah, my understanding is, and this is from communications we've had with Health Canada officials, was that Section 6 is about the first phase. It's like a phased approach. So the first phase is immediately we're going to provide coverage for these two classes of drugs, diabetes and contraceptives, and then eventually, in a year's time, we're going to be working on essential medicines. And so that's, I think, why Section 4 is talking in more general terms, because it's leaving the scope there for covering a wider list of essential medicines. Yeah, I think that's all.
Did you want to add anything?
All I would say is I'm not a constitutional legislation expert, but this certainly speaks to the ambiguity that the experts in the first session mentioned.
Okay, thank you.
Thank you, Senator Cardozo. Senator Meji.
Thank you, Madam Chair. This is not a question. It's actually a request. With your permission for Mr. Nason from the conference board, could he table with our committee his report on the 2.0 gap regarding prescription drugs? This could be very helpful for us, unless we already have it. August 2022. Do you have it?
Thank you, Senator Meji, for the request. It is an important request and would help us a great deal. Unfortunately, if it's not already translated, It is.
It
Well,
should be
then,
available.
please.
It should be available online in
Thank
both
you.
official languages.
Wonderful. Thank you. That's wonderful. Thank you for
Board website. It should be available in both official languages, I believe. I would have to double check.
colleagues. I think that brings us to the end of our questions. I wish to thank our panelists very, very much for appearing in person and online. You have helped us understand the various contours of this legislation. Colleagues, we will resume our study of C-64 next Wednesday at 4:15 p.m. There being no further business, we are adjourned.